about these
SLE.
SLE. SLE is the only possibility which would give rise to secondary
There
nephrotic
are
syndrome.
I took the history of any medications. I took the history of
What medications can lead to nephrotic syndrome?
sir, and prolonged course of NSAIDs and captopril and venous medications. Steroids.
Okay, so obviously these histories were not there. So right at the outset when he started having these complaints, did you consider that he was falling into the category of typical nephrotic syndrome?
Certainly, age was supportive of typical nephrotic syndrome. Plus, I could ask about the biopsy of the patient.
Biopsy, is the biopsy indicate or biopsy, would that be important?
No, sir, at that time, at
Other-
that age, it got
What other-
unless
Typical
other
nephrotic
supportive-
What other points did favor this?
मैं कुछ और
was
सोच
There
रहा
was
हूँ।
hypertension, hematuria,
Was there hematuria present?
no.
So history of hematuria was that, did you ask about history of hematuria?
I asked about urinary complaint, but I typically didn't ask.
Any discoloration of urine?
Hypertension,
And
hematuria.
did you ask that was he hypertensive right at the outset of the illness?
I couldn't ask about the initial pregnancy.
So you considered any other feature you should have asked about that this was typical nephrotic syndrome? Any other history which could have pointed to that?
I responded to steroids initially.
He
and
was
plus
started on steroids.
Steroids and he responded well. And there is all age was.
How long the steroids were continued?
It was continued with a tapering till 1 year.
So for how much duration of the time daily dose was given, and then how long did the tapering take place?
Specifically, yeah.
So what happened afterwards? Did you consider that he responded to steroids? Then did he relapse afterwards?
So he remained symptom free and medication free for 1 year and then again got relapse.
How long the initial treatment lasted?
1 year.
1 year. So for whole 1 year, what was the reason for giving? Is that usual for the initial treatment to be given for 1 year? Did you ask the patient that why the treatment was so prolonged? Or?
I should have asked.
So what happened afterwards?
So he remained symptom free for 1 year, but then again relapsed, presented with a similar body swellings and started on steroid, but didn't respond.
Mm-hmm. Did you ask that were there any triggering factors for the relapse? Mm-hmm. Okay. And just go on describing then what happened afterwards.
So he was started with the steroids, but later he didn't improve with the steroids. He also got one episode of hypertensive emergency at that time and was remained admitted, but then no regular medications were started. Later on, when he didn't respond to steroids, he was started with immunosuppressants.
How long did you come to know? How did you come to know that he didn't respond to steroids? What was the point in the history which
But they were
suggested?
saying that he used to get blood tests, urine tests, and protein urea never resolved.
So what was the extent of protein urea?
So she said it was +2.
+2. She never said this was +2. She said that this was +1. Would that indicate that this was failure of response to treatment? And how frequently did she test? She was testing urine for herself. For herself?
मुझे वही लग रहा है उसके पास।
So
कौन था वो? कौन सा दिखता वो?
What about in between when you said that he didn't respond to steroids? Was that only the 1+ protein which was in the urine, or were the other manifestations persisted
body swellings were also not resolved. It resolved just last 1 year.
for 1 year? So he never had subsidence of edema and
After second relapse.
after second relapse.
He didn't, after first relapse, he
Mhm.
didn't get, his edema didn't get settled till last 1 year. When he was started with immunosuppressants, his edema is settled.
Now how long has he been taking the alternate drugs?
1 year.
1 year. And he's getting inograph. Did you ask the dose that what dose is he having?
So I asked about the dose. She said she's taking 2 tablets only.
2 tablets OD. Okay. So and now he's in remission, in your opinion. You said that
Currently
he's.
again presented with a relapse.
When did he present with relapse?
So 8 days back.
8 days back. But prior to that, he didn't have any edema. He responded to treatment.
Yes, sir, for last 1 year.
Then why are you considering that this is late steroid resistant?
Sir, because he didn't respond to the steroids on first relapse. When inograph was
But
started.
anyway, if the patient is responding to alternate drugs, even then you would not consider that he's. So obviously, the alternate drug must have been started with certain reason. Was that started because of the steroid resistance, or was that started because of something else, because of some other indication? Because now you said that he's been unwell for the last 7-8 days, presented with edema and presented with oliguria. That was the complaint. So this is the recent episode. Has he been all along taking inograph and
Sir, he's taking inograph for last 1 year.
for last 1 year?
1 year.
And during this time, prior to this, just 8 days till 8 days back,
His complaints were resolved.
his complaints were resolved. Then how can you say that he's late steroid resistant or?
Because he couldn't just got improved with the steroids and immunosuppressants were started in addition to steroids.
How would you said that he had episode of hypertension. When was that? And he went into an hypertensive encephalopathy.
Yes, sir.
When was that?
It was 2 years back.
2 years back. And did he receive? You said that he didn't receive antihypertensive drug
After that,
afterwards.
according to sir, his blood pressure is currently 110/70, and mother also says that he doesn't get any regular
Do
antihypertensive.
you consider 110/70 is normal for his age at the moment?
He is 11 years.
11 years. So is that normal? Do you, in your opinion, is that normal for age? What would you regard as hypertension at this age?
Sir, hypertension is more than 95 percentile for age and sex, but it should be plotted over percentile part.
Okay. Now, you asked about certain other points in the history that, and you specifically mentioned 2-3 times that he didn't have any weakness of any parts of the body. What was in your opinion?
I wanted to rule out thromboembolic phenomena.
Weakness of any part of the body, would that be indicative of thromboembolic phenomena?
Sir, I wanted to ask about hemiplegia.
So had hemiplegia been there, so mother should have told you. What about abdominal pain with fever?
Sir, I wanted to ask about the complication of SPP.
Why were you particularly interested in that?
Sir, I wanted to rule out the complications of
Complication of nephrotic syndrome. Okay. And swelling of legs? Swelling of legs. Swelling of legs anyway would be because of the disease itself. Would that be, is that thrombosis in your mind? When do these children are more likely to get thromboembolic phenomenon? Children with nephrotic syndrome. At what stage of the disease they are more likely to get these complications?
So when they get pronounced dyslipidemias, then thromboembolic.
Dyslipidemias. Is that the underlying reason for thromboembolic phenomenon?
So thromboembolic phenomena occurs due to loss of anticoagulants.
Okay. You asked about gum swelling.
I wanted to rule out the complications of drugs.
Which drugs?
I know that.
Anograph leads to gum swelling. And you asked about hepatotoxicity, whether the child underwent any dialysis. So what is the implication of these
I
questions?
wanted to rule out the complications associated with treatment and disease.
Like complication of which? Complication of disease itself, would their hepatotoxicity be associated
No,
with
sir,
that?
it's due to drugs, hepatotoxicity due to drugs and
Like which drugs?
ionograph, cyclosporin, salt hepatotoxicity.
He took only an ionograph. There is no history of taking any other drug. So ionograph leads to hepatotoxicity. What does ionograph lead to? What does ionograph lead to? What are the side effects of ionograph, which you should have asked because he's been there. He's been on ionograph for the last 1 year.
Hypertension, renal insufficiency.
These are very dreaded complications. But what are the usual effects of ionograph which need to be monitored, more important than these?
Immunosuppression.
Right?
Immunosuppression.
Immunosuppression anyway, immunosuppression would be there because of the steroids or because of all the drugs. You asked that did he get any extra vaccinations? What about that? What extra vaccination are
I
you
wanted to ask
interested in?
about influenza and pneumococcal vaccination. Yearly influenza.
Is pneumococcal vaccination not included in the EPA program?
It is included, but before starting steroids, we give pneumococcal to the nephrotic.
Even if the child had, which pneumococcal vaccination would you like to give?
Like for this age, age is 23.
Pneumovax 23. So, what vaccine is included in the EPA program? What pneumococcal vaccine is included in the EPA program?
13.
What?
13.
PCV 13. Do we have PCV 13 in our EPA program? How does it differ from the pneumococcal 3 vaccination?
It covers different strains. Lesser strains are covered with a PCV13 and more strains with a PCV20.
Is that a major difference? What is the major difference between Nemo 23 and PCV 13 or PCV 10? PCV 10 is, by the way, is in our EPA program, not the 13 one. So what is the difference between these two vaccinations? Okay, now coming back to your, did you have any other, did you rule out that, though I believe that with this history you would consider that this is nephrotic syndrome, but did you rule out other associated conditions which can give rise to episodes of edema in any child?
He was a known case, so I didn't rule out.
Did the mother know that he is having nephrotic syndrome?
She said that he is having proteinuria.
Proteinuria can occur due to other reasons as well.
In response to steroids and
Proteinuria can occur because of heart failure. Massive proteinuria can occur. Or did he have any episodes of diarrhea? Okay. You on examination you said that he is Cushingoid and he has evident steroid toxicity. You didn't mention about blood pressure आपने भी बताया presentation में भी बताया. And you said that gait is normal. You said that he has Gowers sign, but gait is normal.
So he has difficulty walking due to the pain. Actually, there is an ulcer at the gravity-dependent area.
How do you know that this is due to the pain in the ulcer area, or did you check for the reflexes? Did you check for the? Okay. You also said that he has decreased air entry in the right lower zone. Those lower zone, you never say that this is lower zone. Zones are radiological zones. When you describe clinically, you need to mention lower part of the back of the chest or interior chest. But anyway, you said that the air entry decreased in lower zone. What is that due to?
Because vocal resonance was also decreased, plus there was skull percussion.
So there was you consider that there is pleural effusion. Minimal or this is clinically evident that it means this is not minimal. So, but you said that there is no ascites. So, would you regard this as effusion as some infection, or due to maybe pneumonia, or would you regard this as due to the disease itself? Must be ascites, but there is no ascites due to this one. If ascites has resolved, then effusion should have you consider that this effusion is because of the concomitant complication pneumonia? What infections generally do these patients get? Nephrotic patients. You said that SPP is one complication. What other infections do these patients get most often?
So they can get pneumonias, they can get ear infection.
Most common infection. One is SPP. What other infections? Pneumonia, yes. Any?
The ear cellulitis, they get most of the time.
Now coming back to your primary diagnosis, that you said that he is having steroid-resistant nephrotic syndrome, and currently he is on inograph and daily dose of steroid or alternate
So
steroid?
he is getting
Daily dose. How many? How much prednisone is he getting?
2 tablets.
It's 10 milligram. He's getting 10 milligram daily plus inograph. And you said that he is currently not in remission.
Currently,
He presented relapse, but has so.
edema is not settled yet.
Edema is
Completely
not
putting edema actually.
So is the good to consider that if he had subsidence edema, now and he had been on an inograph and he had been on steroids, would you consider is this prudent to continue with the same dose of the steroid and same inograph in a patient who relapsed while he was on these drugs?
Because infection should have been ruled. Any triggering factor that led to the current relapse, if that is treated and still patient is not not improving, then the
But
dose should be readjusted.
My question is that why are this? Because you have not started steroids, you have not seen whether there is a steroid response or not. So either you could not elucidate the history properly, or because otherwise, if the patient was alright on these drugs, then you can't call that this is steroid resistant. Or if he relapsed, then he should have been started with the induction of the steroids or whatever treatment is to be followed. Now, at this point of time, how would you investigate him further?
Sir, I would like to check the urine complete examination for protein urea, renal function tests for.
And how much protein-urea would be significant as regards the relapse is concerned?
+2 or more.
+2.
Relapse for that.
Relapse is +3. If this is +2, then this would not be relapse.
So it would be relapse, but this can be due to any intercurrent infection.
Intercurrent infection would give rise to +2 proteinuria.
This can give rise to
Okay. So, what specimen particularly you would be testing? What about the timing of checking of urine? What
Sir, early morning.
Early morning. Why do you prefer early morning?
Sir, as patients get orthostatic proteinuria as well, that's why early mornings happen.
So as to eliminate the aspect of the TK. So one is that you would check for whether the patient is having proteinuria. Any other test?
Sir, monitor RFTs for complications of disease plus DSR.
Complication of disease.
Disease plus treatment.
Complication of disease, like what would
Sir,
this?
he is having steroid-resistant nephrotic syndrome, then it can lead to renal insufficiency as well. So I will monitor for RFTs as well.
So RFTs, anything else?
Plus blood pressure monitoring and BSR.
BSR. Why would you monitor BSR?
Sir, as patient is taking steroids, so there can be a.
Is that the only reason? In his case, is that only the reason for checking BSR because he's getting steroids?
Plus there can be associated diabetes with the
Associated diabetes. Diabetes itself, per se, diabetes can occur in these children. Why would diabetes occur in these children on top of nephrotic syndrome?
Not on the top of nephrotic syndrome.
Okay. Any other investigation you would like to do?
So I would like to go for the biopsy, renal biopsy.
Renal biopsy, okay. What indications do you consider at this moment of that renal biopsy is imminent?
Sir, age of the patient.
Age of the patient, age you would consider if the child started having the problem, then the age would not be a consideration because
Steroid resistance.
steroid resistance. So, in your opinion, steroid resistance is the indication for renal biopsy.
Plus there is sort of hypertension, but I should have ruled out about hematuria and complement level should be done. And
Would you like to do complement at this juncture? Would you like to do complement levels now?
complement level
Should have been done. So it's the fault of nephrology department not to do this
it
complement.
might have been done, but I
Okay.
didn't know.
Okay, anything else? Any other investigation? Okay, now, you said that you would do are there any preliminary investigation before you do the renal biopsy?
Sir, CBC should be done, mass PT should be done.
So you would like to do the coagulation profile, reading in coagulation profile as prerequisite for renal biopsy. Okay, now you have done the renal biopsy. What do you think, what could be the underlying histopathology?
Sir, there can be focal segmental.
Do you consider focal segmental would be the most likely histopathology?
Sir, the age before 10 years and steroid resistance.
Age before 10 years. What is the usual age for focal segmental glomerulosclerosis?
Sir, it's 2 to 10 years.
2 to 10 years. So what is the age for minimal change disease?
2 to 6 years.
2 to 6 years, not 2 to 10 years. So how would the ages be different? Can you differentiate right at the outset between focal segmental? What else? What is the most common histopathology or what is the most common reason for nephrotic syndrome in children?
Minimal changes.
Minimal change disease. So how would it focal segmental? You said that now it's more likely to be focal segmental.
As the steroid resistant, minimal change, 90% of minimal change patients respond to steroids.
So he did respond to steroids. It was only afterwards because there are chances again that even with minimal change disease patients may not initially respond to steroids. Certain number of those, that is less, or afterwards they, about 5-6% may become less steroid resistant, even in minimal change disease. So what is the differentiating point? Were there any differentiating points right at the outset which could have pointed towards focal segmental glomerulosclerosis or other types of idiopathic nephrotic? What are the other types of idiopathic nephrotic syndrome? One is
Membranous nephropathy.
membranous nephropathy.
Membranoproliferative.
But more commonly, which would be the typically idiopathic nephrotic? One is focal segmental, minimal change, and what would be the third?
Membranoproliferative.
Does membranoproliferative present like minimal change disease? How does membranoproliferative most often present?
So it presents with hematuria, hypertension.
So that would be the more florid presentation. So one would not, though membranoproliferative is under the category of idiopathic, but that is not the common one because that would be differentiated early. So what would be the third most common underlying histopathology, which we call as idiopathic nephrotic syndrome? Mesangial proliferative nephrotic syndrome or other similar diffuse mesangial proliferation. Okay. So why do you consider that this is most likely to be focal segmental? Do focal segmental patients respond to steroids?
Sir, few 20% of patients do respond to
They do respond to steroids. So what other features would differentiate between minimal change disease and focal segmental?
on history examination or on lab?
Any other?
Focal segmental patients are more likely to have hematuria than minimal change disease. They can present with a
चलो मुझे
hypertension.
ये टाइम ऊपर हो गया ये बताइए, tell me that why was he started on inograph? straight away why was it started on, in
मुझे
your
भी कर
opinion?
देना
Had it been more
नेफ्रोटिक खत्म कर देना
maybe
मैं
justified to
नेफ्रोटिक
give why this alternate drug was started, in your opinion?
Sir, as he was getting steroid toxicity signs as well, so
So
was
would you, if you follow the sequence of the drugs which you generally give in nephrotic syndrome, why not? Why if this was, he was getting steroid toxicity, why not cyclophosphamide?
in steroid-resistant patients, we give
You mentioned that this was steroid toxicity, not the steroid resistance. For that reason, if inograph was started, so why not cyclophosphamide?
Sir, cyclophosphamide, as his male child, and cyclophosphamide causes hemorrhagic cystitis, plus there is
Hemorrhagic cystitis, it doesn't lead to hemorrhagic cystitis in girls.
no, it also causes azoospermia in males, that's why fertility is
What is at what particular age would it lead to azoospermia?
Sir,
Invariably this would lead to azoospermia, then why this drug
the
is there?
dose increase up to 250 milligram.
Increase up to?
250 milligram per kg cumulative dose.
So avoid that dose, avoid that cumulative dose. So why not to use levamisole as an alternate initial steroid sparing drug?
So it is used in steroid dependent nephrotic syndrome usually.
Steroid dependent.
Lavicol is used in steroid dependent.
I think because of lack of time, I would stop here and there are a few actually. First of all, I would advise you that first of all, you should straight away started asking the leading questions, because you are putting words in the patient's in the mother's mouth. You said because she started with oliguria, then you said the swelling हुई थी और इसके बाद बाकी और जगह क्या हुआ था, कैसे हुआ था. So let the mother speak about the illness. आप पहले 5 मिनट the mother should give a brief account of the illness. आप कहें कि मैं आपसे सुनना चाहता हूँ सुनना चाहती हूँ कि आपके बच्चे को क्या क्या है, कब से है और इस वजह से tell me all the details of the child's problem. Then you go on to asking maybe the pertinent questions which in your opinion were not told by the mother. ठीक है, तो जो आप straight away बाकी मुख्तलिफ चीज़ें जो है ना आप respiratory distress, walking difficulty right at the outset, etc. So obviously let the mother speak. Then देखिए history में ये important होता है. History में apart from the presented complaints, you listen to the patient and then keep in mind the पहली बात तो ये है कि you have to elaborate the symptoms. You have to consider the differential diagnosis obviously of those symptoms. Thirdly, the problems which can be associated with that complaint or that illness. And fourthly, the treatment and treatment detail, the impact of treatment, and then finally the current status of the child, because the current state of the child is important. That how did this illness evolve and what is the present situation. तो ये सारी डिटेल्स फिर उसके बाद आप बाकी जो है ना चीज़ें बिल्डअप करते हो, ठीक है. और डेवलपमेंट में ये अब चाइल्ड हु इज स्कूल गोइंग इट वुड नॉट बी वेरी would not look that he started walking at normal age, because you would obviously development में current जो है ना या तो बच्चा development delayed हो, current situation ज़्यादा पूछते हैं और otherwise बाकी you went well and but regarding you could not actually prove the point that this child is steroid resistant, because all along you told that he was initially responsible to treatment, relapsed after 1 year, now being on alternate drug he continues to be in remission. So that doesn't prove the point that he is steroid resistant, because that was the major factor in that. Then coming on to the drugs, At your level, even we would expect that you should know the major side effects of the drugs, or how would you start drugs, alternate drugs, and the major side effects of drugs like inograph. You're not very familiar with the inograph. कि वो inograph अगर दे रहे हैं तो उसके बारे में पता होना चाहिए कि किस तरीके से मॉनिटरिंग करेंगे. और inograph की मॉनिटरिंग में ग्लूकोज मॉनिटरिंग बहुत ज़रूरी है. Renal functions inograph less likely compared to cyclosporin. Renal function prolonged use renal function disturb करेगा. They can more often with glucose. Glucose is important. Diabetes is important because hyperglycemia is the major complication of this tacrolimus. And secondly, the magnesium, hypomagnesemia is a very frequent complication. So you should know the complication of drugs, and you should know that how would you start alternate drugs and what are the specific indications for alternate drugs. TK, you were not very clear about vaccination. At least one should, because we expect from you that you should be clear about Pneumo 23 polysaccharide vaccine, or what we were talking about, that was the conjugate vaccine. The polysaccharide or conjugate vaccine, and there is a world of difference, both in memory, both in frequency of administration, etc. Yeah, बाकी ठीक है. Any questions from the resident? देखिए steroid resistant nephrotic syndrome either at the outset जो initial steroid resistant stage है उसको आप जिस तरीके से the definition would vary. Some would like to give 4 weeks treatment, some would like to give 6 weeks treatment. लेकिन ये anyway आप initial steroid administration के साथ resistant. So some would like to, because there can be different schools of thought. Some would like to give the antihypertensive pulses before declaring. Basically, patient who is not responsive to steroids, generally 4 weeks of treatment.
The late non-responder.
Late non-responder, if he has failed to respond to steroids, generally speaking, with steroids, if he has failed to respond to steroids, then we would call that as late steroids.
What had to be present to call this patient late non-responder?
Late non-responder, actually he might be late steroid resistant, but this was never mentioned in the history, because why was he started on, you said that he was started on in inograph because of the steroid toxicity. So this should have been mentioned, that he was given for how much time the steroids were administered before starting inograph. And generally what happens is that the response to second line drugs generally would be more in those patients who are steroid responsive. Because those patients who are not steroid responder, they would less likely be responding to alternate drugs. और उस वक्त अगर steroid resistant nephrotic syndrome है, then obviously as a matter of fact that would become even late steroid resistant, so that becomes as a matter of fact indication for biopsy. और कोई question? आपके लेवल पे, because nephrotic syndrome long case में as regard the diagnosis is concerned, there is nothing much in diagnosis. So you should try to elucidate the history. हिस्ट्री में जो इम्पोर्टेंट पॉइंट है, आप पहली बात तो यह है कि यू हैव टू डिटरमिन टिपिकल है या एटिपिकल है. फिर उसके बाद आपने देखना है कि और अंडरलाइंग डिजीज़ हर किसी में नहीं होती, लेकिन यू डिड आस्क अबाउट ओनली SLE, लेकिन बाकी चीज़ें जी नॉक्शन लाइन कैन बी देयर, वेरियस इन्फेक्शंस कैन बी देयर, वो सारी चीज़ें जो है ना पॉसिबिलिटी हो सकती है. सो वो और फिर उसके बाद आपने देखना है कि किस वजह से रिलैप्स होता है और इन्फेक्शंस कैसी हैं और इलनेसेस तो नहीं हुई. वैक्सीनेशन के बारे में मैंने पूछा, एक्स्ट्रा वैक्सीनेशन, स्पेशली वन शुड एज अ नेगेटिव मे बी एज a leading question one should ask about chicken pox or such type, because these are important informations, because if the child has not contracted chicken pox during remission, you would like to give vaccine for chicken pox, because these infections they can play havoc. So ये चीज़ें मेंशन करना ज़रूरी है. फिर उसके बाद किस चीज़ से ट्रिगर होता है और बच्चे की जनरल और बाकी जो वेल बीइंग है उसके बारे में आप जनरली पूछते हो. फिर उसके बाद यू शुड बी लिटिल फेमिलियर कि हाउ वुड यू follow the sequential changes in the treatment apart from steroids when you start alternate drugs. तो और किस तरीके से आप उसको चलते हो, because जनरली तो ये है ना कि अगर आप किसी भी सिचुएशन में अगर स्टीरॉयड डिपेंडेंट है या स्टीरॉयड टॉक्सिसिटी है तो आप मे बी उसमें स्टार्ट विद लेवेमिसोल, फिर एमएमएफ, फिर उसके बाद जो जनरली कंसेंसस है, फिर उसके बाद आप यू वुड स्टार्ट विद कैल्सिन्यूरिन इनहिबिटर्स, देन गोइंग ऑन टू रिट्रोक्सिमैब एंड अदर ड्रग्स। तो ये थोड़ा सा आपको इन्फॉर्मेशन मे नॉट बी इन ग्रेटर डिटेल, लेकिन थोड़ा सा इन्फॉर्मेशन, और ड्रग्स के साइड इफ़ेक्ट्स होने चाहिए। गम हाइपरप्लेजिया साइक्लोस्पोरिन के साथ होता है, और यही एड्ज है आपका टेक्रोलिमस का ओवर साइक्लोस्पोरिन के, इसमें कॉस्मेटिक इफेक्ट्स नहीं होते।
सर एक सवाल ये था कि प्रेजेंटेशन जैसे 4 ईयर बैक ये डायग्नोज हुआ है, तो हमें अभी भी उसकी प्रेजेंटेशन जो आई थी कि उस वक्त हमें सीसीएफ को रूल आउट करना चाहिए, प्रोटॉन लूजिंग एंटेरोपैथी को रूल आउट करना चाहिए, यानी अभी हमें डायरेक्टली कहना चाहिए कि इज नेफ्रोटिक सिंड्रोम, केस ऑफ नेफ्रोटिक सिंड्रोम, और हमें उस वक्त की डिफरेंशियल अभी रूल आउट करने की जरूरत नहीं।
नहीं, वो तो मैंने वैसे, लेकिन देयर इज़ नो नीड। लेकिन ये है कि आप पूछ सकते हैं, जैसे तो हार्ट फेलियर को किस तरह रूल आउट करेंगे, वो तो ऑब्वियसली हार्ट फेलियर अगर हो तो वो तो प्रॉब्लम रहेगा, और प्रोटीन लूजिंग एंट्रोपैथी या मेल एब्जॉर्प्शन सिंड्रोम्स हो रहा होंगे तो दैट वुड बी क्वाइट डिफरेंट। लेकिन ये है कि आप वैसे तो पूछ सकते हो एज पार्ट ऑफ इन्फेक्शन, डायरिया तो नहीं हुआ। आई एग्री कि 4 साल पहले अगर हुआ है तो उस वक्त पूछना चाहिए कि बाकी ऑल्टरनेट चीज़ें भी, और उस वक्त ज़्यादा जो पूछना चाहिए वो टिपिकल फीचर्स है, एटिपिकल फीचर्स, उनके बारे में फिर भी पूछना बहुत ज़रूरी है। इमेचुरिया इज़ वेरी इंपॉर्टेंट पॉइंट इन द हिस्ट्री, हाइपरटेंशन इज़ अ वेरी इंपॉर्टेंट पॉइंट, और बाकी जो इंटरकरेंट इन्फेक्शन नहीं, कॉम्प्लिकेशन ही मैंने पूछा था, इन्होंने कहा कि थ्रोम्बोएम्बोलिक फिनोमेना, आमतौर पर थ्रोम्बोएम्बोलिक फिनोमेना जो होता है वो वैसे तो कनेक्ट कर नहीं गया, बस नथिंग, आप डॉगमेटिक कोई भी नहीं दे सकते। लेकिन मैंने हैपन deep vein thrombosis is more common, deep vein thrombosis more often occurs during the first 3 months of the start there, और फिर उसके बाद ये है कि इनिशियल स्टेज होता है, फिर उसके बाद कंजेनिटल नेफ्रोटिक सिंड्रोम में ज़्यादा होता है, मेम्ब्रेनस नेफ्रोपैथी में ज़्यादा होता है, एसएलवी में ज़्यादा होता है, ये चीज़ें। लेकिन ये है कि इनिशियल 3 मंथ में
अभी वार्ड में
ज़्यादा
स्कूल बनता है ना, तो जब
Sir,
स्कूल जाएगा वहाँ
Sir,
जाएंगे,
if
स्कूल में
patient is
मिलेंगे।
taking a steroid system type of drug, long dose steroid system, so it's wise that you can start if patient is responding to the steroids. We can directly jump on the drug belongs to the steroid resistance class drug.
I couldn't, because you said that if he's on alternate drugs and if he relapses, उस वक्त आप कहते हैं कि उस वक्त क्या करना
So,
चाहिए?
sir, patient के steroid respond कर रहा है
हाँ, हाँ।
ट्रीटमेंट, अब साइन ऑफ steroid toxicity आ रहे हैं या तो अब हम अगर सेकंड लाइन पे जाना चाह रहे हैं,
हाँ,
तो हमें एमएमएफ जो साइक्लोफॉस्फामाइड है या लेवेमिसोल में जाना चाहिए कि हम साइक्लोस्पोरिन पे या जो कैटरेस है
नहीं, वो आप कोई भी फॉलो कर सकते हैं, लेकिन ये है कि साइक्लोफॉस्फामाइड के लिए स्पेसिफिक कुछ है, पेरीप्यूबर्टल बच्चों में आप अवॉइड करेंगे, यू वुड लाइक टू गिव maybe MMF or calcineurin inhibitors. There can be there can be personal liking, disliking as regard the stuff, our personal experience. लेकिन generally speaking आप जब आमतौर पे जो साइक्लोफॉस्फामाइड आमतौर पे उन बच्चों में करती है, ज़्यादा इफेक्टिव होती है जिनमें नेफ्रोटिक सिंड्रोम ड्यूरेशन जो है ना 2-3 साल से ज़्यादा हो, बच्चा 5 साल से ऊपर हो गया हो, लेकिन यह है कि पेरीप्यूबर्टल ना हो। पेरीप्यूबर्टल अगर होता है then you would avoid the generally cyclophosphamide or chlorambucil because of the gonadal toxicity. अगरचे आप cumulative dose जो है ना वो 250, लेकिन यह है कि generally 166, 160, 170 से ऊपर आप you would try to avoid because the chances of complication would occur more. तो वो कोई भी आप फॉलो कर सकते हैं। लेवेमिसोल हैज़ अ माइल्ड स्टीरॉयड स्पेयरिंग इफेक्ट। शी इज़ राइट दैट को जो फ्रीक्वेंट रिलैप्सर है, स्टीरॉयड डिपेंडेंट है और मेंटेन नहीं हो रहा बच्चा, उसमें आप लेवेमिसोल ट्राई कर सकते हैं। तो लेवेमिसोल के वेरिएबल रिजल्ट्स हैं, इट्स अ मोर फेवर्ड ड्रग एज फार एज द ब्रिटिश school of thought is concerned, not being used in that much in US.
And sir, what about MMF?
MMF is considered to be the first. MMF बल्कि ये है कि पहले MMF ट्राई करनी चाहिए, लेकिन MMF के बारे में कहा जाता है कि MMF जो है वो जो बच्चे जो लेट जिनको रिटुक्सीमैब मिलती है, रिटुक्सीमैब के बाद उनको मेंटेन करना एमएमएफ से ज़्यादा फीजिबल रहता है। लेकिन एनीवे एमएमएफ आप कर सकते हैं। एमएमएफ जो है उसकी नेफ्रोटॉक्सिसिटी नहीं, दैट इज़ द बिगेस्ट एडवांटेज ऑफ एमएमएफ। बट एमएमएफ बाद बच्चों में जो गैस्ट्रोइंटेस्टाइनल सिम्टम्स बहुत ज़्यादा करती है, तो दैट इज़ द मेजर प्रॉब्लम। अदरवाइज एमएमएफ इज़ अ गुड ड्रग।
Thank you.